And then in advance, Happy Pongal and then Sankranti. On behalf of Anbai, AP and TS, I invite you all to this teaching session of webinars. Henceforth, this will be a regular phenomena from our side. And the classes which we deal are more from the broad and super specialties. And then the idea is of taking over this is to mainly focus on the teaching, the clinical aspects. I think our students are very good in the theory aspect, but slightly lagging behind the clinical material and then clinical examination. So we thought that we should focus more on clinical, and then hence we have selected topics also in clinical examination. So such class is from the cardiology today. So I invite the eminent cardiologist, Dr. Pramod, who is very much uh, efficient in his form in the cardiology and then more a physician also. Before going further about the details of the speaker, I would like to thank Dr. Alex, Dr. Venkat, and Dr. Srinath from Central Mumbai for giving us this opportunity to host these classes. Now, our distinguished speaker, Dr. Pramod, an eminent cardiologist, did his MBBS from Siddhartha Medical College, Vijayawada, and then he did MD from Usmania Medical College, Hyderabad, and DM from King George Hospital Medical College, Lucknow, and he's got fellowship from Washington Hospital, DEC, USA. Presently, he is working in Yashoda Hospital, Somajiguda, as a senior interventional cardiologist. He is a DMB teacher for the last 15 years and an interventional cardiologist with 25 years experience. He is very good at the complex coronary work, and he did over more than 10,000 PTCS. And then he is also specialized in doing the procedure of TAVI, that is aortic valve replacement transcutaneous. And like any other cardiologist, he too has got the publications of national and international level, and he's a good clinical cardiologist. That is the reason why we have asked him to take over. I've already told that our students require more of clinical exposure. So he's, and then chest pain is such a symptom, and then that will be usually causing more concern for the patients as well as the students also in evaluation. So we requested him to talk on the chest pain evaluation. He readily accepted. Thanks to Dr. Pramod. Now, may I request Dr. Pramod to go ahead with this topic? Dr. Pramod.
Thank you very much, sir. And I also thank Ambai for giving me this opportunity. And it's always a pleasure to talk to the students. And the topic that I'm requested to talk about is the approach to chest pain. So I think I believe that a proper analysis of the symptoms is very important for guiding the patient, because the initial interaction with the patient is going to determine what system is affected. For example, if you take a proper history and make a diagnosis of a coronary artery disease, the patient will be channeled through a cardiology department. But if you fail to do so, and if you wrongly direct the patient to a gastro or some other department, which sometimes happens, we see in our day-to-day practice as well, and the patient is misled and a different direction will happen. So we have, all of us, seen in our experience that patients sometimes go to a different physician, altogether a different direction, and finally they may end up with a catastrophe. So always the analysis of the symptoms, especially with regards to the chest pain, is very important, because if you miss a gastric ulcer or a cervical spondylitis or something, if you misdiagnose, it is not going to press itself as an emergency. But if you miss a coronary disease, the patient is likely to present with an acute myocardial infarction, which may be associated with a mortality as well, which is a sudden cardiac death. So therefore, analysis of the symptoms is very important. And at the same time, it's not so straightforward and easy, But if you look at the symptom presentation, almost 90% of the symptoms are reproducible. So if you take a history of angina, ages together, we have seen patients present with the classical symptoms of angina. So it is important to know what are the classical features so that you will not miss a common case. See, always uncommon things you may miss, but a common thing you should not miss. And that is the purpose of this discussion and a clinical presentation. So if you see here, the history taking and clinical examination is important clinical skill. And despite numerous technologies, these skills remain crucial for accurate diagnosis. And a complete history can establish the diagnosis in almost 80% of the cases. I always tell the students that you don't have to do anything. The patient will give you the diagnosis. Only thing is you should have time to listen to the patient. So if you listen to the patient carefully and jot down the symptoms and then apply your brain and see what is the main problem, then you can arrive at a diagnosis in the history itself. The clinical examination and subsequent investigation is only going to supplement what you have made on the basis of a clinical presentation. And good clinical skills are foundation for a successful doctor-patient relationship as well. And as you know, nowadays, the interaction is becoming less and less. When the patient is talking to us, we are jotting down the symptoms. So that eye contact, which is very essential, is missing. And that is one of the important things which establishes a good connection with the patient. So here is one example I want to present. This lady is a PhD scholar. This actually happened in 2009, as you can see there. I have put this because it's a public information value. Don't ignore the chest pain. That is what I wanted to convey to the lay people. So here, this lady is premenopausal, and she presented with the chest pain early in the morning, around 1 a.m. to our hospital with some vomiting. So the duty doctor he has seen, he did an ECG, and he said, okay, this lady is premenopausal, there are no risk factors, so it cannot be a cardiac. You just go home, that is what he said. The lady went home and she continued to have a severe chest discomfort and vomitings. And then she was having a lot of sweating. And then she came back to the emergency room again to the same hospital. Another ECG was done, which revealed acute anterior wall myocardial infarction. So immediately I rushed to the hospital around 3 a.m. And then we did a primary PTCA and the patient was saved. After that, at the time of discharge, I convened this meeting because she's a PhD scholar. She has described very nicely how she has experienced the chest pain. So I will talk about that when we go in further slides. So it's very, very important. Don't be biased when you are looking at a patient or when you're analyzing the symptoms. Always you take it with diligence, because I always tell the patient is always right. So that is very important. Doctor may be wrong, but the patient is always right. And with regards to the chest pain, this is a cardinal symptom of cardiovascular disease, and it is the commonest symptom of cardiovascular problems, cardiac disease. But there may be many causes for chest pain. And in outpatient department, it amounts to about less than 25% of the cardiac causes. In emergency, if somebody comes with chest pain, it accounts to more than 70% of the cases. An important task is to establish whether it is a cardiac or non-cardiac. Now, causes of chest pain, as you see, can be cardiovascular, they can be neuromuscular or related to chest wall, they can be gastrointestinal, they can be pulmonary, or they can be others, including anxiety, etc. So most often the doctors or the patients are confused between cardiovascular and gastrointestinal, and the patients usually they take a different kind of medications like antacids, etc. And subsequently they may land up in the emergency room with an acute evolved myocardial infarction, which is also again a common observation we see. Now the symptoms that arise could be from the chest pain causes. One is a neuromuscular or a chest wall symptoms, that is costochondritis, which is the inflammation of the costochondral junctions on the left side, also called Tietze syndrome. It could be chest wall myalgia or trauma. Herpes zoster is another important cause of chest pain. Thoracic outlet syndrome or cervical spondylitis, they all cause radiation also, and they may sometimes reveal themselves as a chest pain. And unless you examine the patient thoroughly and you take the history, you may not be able to make these diagnoses. And when you look at the gastrointestinal causes, there may be gastrointestinal causes related to the esophageal spasm, reflux, or rupture. Then peptic ulcer disease and gallbladder disease, cholecystitis is also one of the differential diagnoses, and then pancreatitis. But of course, if you carefully take the history, then you can make out these disorders. And pulmonary also comes with the chest pain. And pneumonia can present with the chest pain, pneumothorax or pleurisy, tracheitis, bronchospasm, all these things, the respiratory causes also can come as a chest pain. And psychogenic is another common problem. And sometimes non-specific chest pain also is another cause which brings the patient to the hospital. Now, if you look at the commonest causes of chest pain in the outpatient department, they may be related to chest wall pain, about 36%. Gastrointestinal is 20%. Serious cardiac is about 17%. Stable CAD 10%. Pulmonary 5%. Non-specific is 16%. This is the analysis from the published observations from the OPD. So you can see here stable CAD is about 10% of the cases. Other causes, cardiac causes include 17%. So that means about 25%, almost 1/4 of the causes are related to cardiac, whereas others are either pulmonary, gastrointestinal. I already mentioned that the gastrointestinal symptoms closely follow the cardiac, and therefore that comes as the second, it's about 20%. Now, stable chest pain and acute coronary syndrome is also very important. A stable chest pain could be a typical angina or atypical angina, or it could be a non-ischemic chest pain. Main purpose is to differentiate between angina and non-ischemic chest pains, and of course, it is a difficult task. Unstable angina or myocardial infarction or further serious manifestations of the same, and then we should be able to identify by clinical history how to make a diagnosis of an MI or unstable angina, and that is what I am going to tell you and share here and there my experience as well. Now, stable angina occurs at a predictable level of exercise. So this is a very, very important point. In stable angina, actually, angina means chest pain, that is a gripping sensation that is felt in the substernal region, and it occurs at a predictable level. Mainly it occurs because of the supply-demand imbalance. So normally, you know that we have a coronary arteries which supply the muscle of the ventricles, and with the advancement of the age, there will be a cholesterol deposit inside the coronary arteries. And as the time progresses, these deposits will become more and more in volume, and they produce obstruction to the blood flow. Now, when the patient is sitting at rest, the blood flow is enough to cater to the needs of the body. But when a person is doing an effort or doing an exercise, or when he is emotionally disturbed, there is a mismatch. There is a supply-demand imbalance, that is what we call it. So if I am doing an exercise, my body needs more oxygen and more blood. Similarly, my heart needs more blood and more oxygen. But because I have atherosclerotic lesion, the supply is the same. Instead of increasing supply, it is remaining the same. So this supply-demand imbalance will manifest in the form of a cry of the heart muscle, and that is what is called angina. And usually it occurs at a predictable level of exercise. So generally people will go for morning walks, and he says, okay, sir, when I start going up to 1 kilometer, I am fine, there is no problem. But exactly at 1 kilometer, there is a post office or some milk booth, I will start experiencing some discomfort. Then I will wait for 5 minutes, gradually it subsides, then again I move. So this pattern is going on regularly for the last 1 year or say 1.5 years, you will see. But this is not going to remain the same throughout the person's life, because the atherosclerotic lesions will progress. Now, as this goes on, the patient's walking distance will come down. So instead of at 1 kilometer, he will start experiencing at a 0.5 kilometer, or he may come down further. So with time, the walking distance will come down. Same thing happens also with the claudication. In the legs, if he has atherosclerosis, we call it as a claudication. So there the patient experiences pain in the calf muscles or thighs or in the buttocks, if it is the atherosclerosis involving the peripheral arteries. So there you call it as a claudication distance. Here it is also something similar. So the patient in stable angina will be able to walk to a certain level, then he has to stop. So as I mentioned, this is because of the increased myocardial oxygen demand, and there is an imbalance of supply demand. This is the stable angina. Now here some points we have to ask to the patient. Where is the location? Is there any radiation? What is the character or quality of the chest pain you are describing? Are there any aggravating factors? Are there any relieving factors? What is the duration of the discomfort you are having? What is the frequency? What is the mode of onset and pattern? Are there any associated symptoms? And is there any particular posture or a gesture the patient is showing you? So actually, if you look at this, it looks like so many questions. But with practice, we will get to know this in few seconds only. When the patient comes to you in an interview, the patient will tell you where is the location. He will show you. You don't have to waste time. When you ask, is it the same place or it is radiating? He will say, sir, it is radiating to my left hand. Then the character, quality, other things we can question. So always these points will help you to arrive at a proper diagnosis of anginal pain, which is a clinical diagnosis. So you don't have to, angina you cannot diagnose by any test. So that is very, very important. That is why we are telling you the importance of analysis of symptoms, because angina cannot be diagnosed by an ECG. Angina cannot be diagnosed by an angiogram or an echocardiogram. Angina is only what the patient tells. It is a symptom, but it is a very, very significant symptom. Angina is there, definitely some amount of blockages are there, or maybe other causes also, of course, that we will discuss. So angina is the most common clinical expression of coronary artery disease, and the results from supply-demand mismatch. So this point is very important. Time and again we say supply-demand imbalance. That is very important. It is diagnosed only by history. As I mentioned, you cannot diagnose it with any test, and no single feature is diagnostic. You have to combine the symptoms and then analyze. The quality is described by the patient, depends on his intelligence, education, and social background. Of course, when you diligently talk to them and show some empathy, you will get all the information. Good history avoids unnecessary investigation. So if you properly take the history, you will know that definitely it is an anginal pain. So here are two examples to differentiate. In the third example is which I have shown in the beginning. 50-year-old male, acute onset chest pain. ECG showed STT changes. He underwent CAG, which was normal. This patient had a pneumothorax. If an X-ray is done or if you auscultate absent breath sounds, probably you could have made a diagnosis of pneumothorax or looking at the tracheal shape. Another case is 55-year-old male, atypical chest pain for 1 month. Angio revealed borderline lesions. He was treated with a stent, then continued to have discomfort with dyspepsia, and then referred to GI workup. It showed carcinoma stomach. So these kind of changes do happen. We are not saying that there may be associated coronary disease or other disease may be associated, but predominantly the symptom which brings the patient to you or to the hospital should be the basis for diagnosis. So you cannot say that I have evaluated this patient and then made a diagnosis of coronary disease, whereas this patient symptom and presentation is because of a carcinoma, and in the upper case it is because of the pneumothorax. So these things we should be very, very careful in analyzing. So looking historically, this is Heberden, who has described angina in 1772, very, very long ago. And he has mentioned that those who are afflicted with it are seized while they are walking, more especially if it is uphill, soon after eating, or with a painful or disagreeable sensation in the chest. It seems as if it is going to extinguish his life, and he has to stand still, and then slowly it gets relieved. So this is the basis of the classical symptoms which we describe for angina, and this is also known as a Heberden's angina. We have other anginas like a Ludwig angina, but that is the cellulitis of the floor of the mouth. But this angina means actually the coronary only. So Heberden's angina, we can also call it. A typical angina. What is a typical angina? Typical angina has got three important features. One is the location. It is a substernal, and the patient does not often describe it as a pain. He will say it is a discomfort. So the patient says, sir, I am having some discomfort here. And one more important feature is they may say that there is a heaviness. Quality wise, they say heaviness, or as if it is a choking, constricting feeling is there, as if some boulder, that is a huge stone, is kept on my chest. That is the kind of feeling I am having when I am walking. It is substernal, and it is like a heaviness, and then it radiates to the left arm. Most commonly, it radiates to the left arm because, as you know, developmentally, the upper limb inner part, the heart, they develop from the same somatomes, and therefore the innervation is similar, and therefore there is a left arm radiation. Sometimes there may be radiation to other places, but this is an important symptom, and it is brought on by effort, exertion, or emotion. This is the precipitating factor. And the relieving factor is rest or nitrate. Or one more important feature I have added is belching. So many times this is also missed. The patient says, when I have belch, there is a relief. So these are the relieving factors. And the duration is also important. Angina is of not a very longer duration. Angina lasts usually minutes. Maximum it may last 10 to 15 minutes. Beyond that, it will not happen because the patient will stop what he is doing when he is having a chest discomfort. That is the reason why it is limited. If he continues to do it, he may infarct because the supply demand is so much that the vessel may break inside. There is a plaque rupture which leads to myocardial infarction. So these three features, if they are there, it is called a typical angina. So again, I'm going to tell you substernal discomfort with left arm radiation brought on by effort or exercise or emotion and relieved by rest or nitrate and lasts for few minutes, 5 to 10 minutes. So if these are there, it is called typical angina. If one of these symptoms is not there, it is called atypical angina. So typical angina has three symptoms. Atypical means either two or one symptom is there. It is a atypical angina. Still, it is angina only. So radiation usually happens to the left arm. Sometimes it can happen to the right arm. And in the left arm also, we have seen cases manifesting differently. There was one IPS officer while going for a golf, he had a discomfort only in the left ulnar aspect when he was doing the golfing. Then he came to the hospital, he was investigated, treadmill was done, treadmill was all right. The patient presented with acute myocardial infarction in the night. So you correlate, this was the symptom. Only this portion, there was a left arm radiation. So any radiation, especially relation to effort, is the cardinal symptom of angina. So when the patient is performing some activity, going upstairs or carrying a suitcase, playing, walking, up hills, if he is going against a gradient, if he has this discomfort along with the left arm radiation, sometimes radiation to right arm, or it can go to the neck or to the lower part of the jaw, sometimes epigastrium, and then interscapular. So these are the sites where the anginal radiation can happen. And there are some clinical clues also. If the patient has an epigastric radiation, most often the right coronary artery is involved. Similarly, if he has got a jaw pain, that is also important. It may be a right coronary artery involved. And if he has an interscapular radiation, we have seen many times, there is a left main or a LAD involvement. So these are the pointers to the presentation that there is a cardiac symptom, that is the blockage of the coronary artery system. And sometimes they may have associated symptoms. So they may be a sweating, anxiety, fear, palpitation, nausea, vomiting, weakness, sometimes shortness of breath, extreme weakness. These are other associated symptoms that should also be recorded and taken cognizance. Please mute all of you, some background noise is there. So this diagram shows the different radiation sites. You can see the radiation does not happen above the jaw and does not happen below the umbilicus. So this is also another important clue to identify angina. So you can see here it radiates to the neck or to the jaws, both shoulders, inner arms of both sides, most commonly the left arm, epigastrium, and sometimes also interscapular. So this is the radiation pattern of angina, which does not happen with other disorders. So that is also very, very important clue. You must ask, is it radiating or not? You may not ask a leading question, but if you ask the patient to describe more in detail, he will come out with the radiation. And this is called Levin's sign. Maybe ask you as a multiple question, or in the exam, somebody may ask, what is a Levin's sign? So this is a classical sign. One or two clenched fists holding and patient is bending like this over the sternal area. And this is a classical anginal pain or a myocardial infarction pain, which means the patient comes to the hospital. And it's also important to know what is not angina. So I have told you what is angina. Now let us see what is not angina. So knowing this is also very important. So any chest discomfort that is a stabbing type, sharp or electric shock like or shooting type of pain, which lasts a few seconds or which lasts several hours, or it can be localized with a finger by the patient. It is aggravated or relieved by local pressure, unrelated to effort or exercise, not relieved with rest. So these are the counterpoints to say that it is not angina. So among these things, generally what I do is when the patient comes and says, sir, I'm having a chest discomfort, I ask him to show me exactly where he is having the discomfort with one finger. So if he's able to point to a location with one finger, most commonly they will say left inframammary. That is the commonest presentation they will say. Sir, I am having a pain here. With one finger, he will say, here is the pain. So if he is able to localize with one finger, it is highly unlikely that is angina. It is highly unlikely, you can say. And then again, you ask him, what is the type of pain? He will say some electrical thing, or some spark is coming in my chest, or some shooting type of pain, stab, which lasts few seconds. So any pain that is lasting few seconds, 20 seconds, 30 seconds is not angina. And similarly, if he says, sir, I am having this pain from 2 days, continuously it is there, that is also not angina. And second, you have to ask, is it same in the past? Suppose if he says 48 hours, the pain is there, it cannot be a angina pain, because angina, as I told you, is a time bomb. It is 5 to 15 minutes, maximum 20 minutes. Beyond that, it cannot be there. So always you can look into other causes. And if you press at that spot, if the pain is increasing, the local tenderness is there, that is definitely non-cardiac. And similarly, if he says, I am getting a relief, when you press here, sir, I am finding it very well, I am having a relief. If he says that, definitely you can say that it is not angina. And other features, like unrelated to effort or exercise, I am sitting. Nowadays, what happens is with this lockdown and all, people are working from home, they are sitting at the computers, the ergonomic postures are not good. They have so many muscular pains. And it is unrelated to effort, and they complain of discomfort. And it is not relieved with rest, because it is not occurring on exercise, it's not relieved with rest. So these are the features which say it is not angina. So again, the summary of this table shows what is ischemic cardiac pain and non-cardiac chest pain. I discussed, I think, all those points. So these things are important. The same thing is mentioned. I know there are many varieties we described as angina. All those things are historical, and it is better to know the mechanisms, at least, because it helps you to analyze the symptoms. So there are many terminologies we use with the angina. We say stable angina, unstable angina, nocturnal angina. All those things are there. So briefly, I want to tell you about that. Postprandial angina is another important thing. So the patients with angina, they say after having a meal, when I am lying down, I am getting angina, chest discomfort is having. So it may occur during physical activity after meals. It is a likely marker for severe coronary disease. This is very important, and it is identified in up to 10% of the patients with chronic coronary artery disease. And the mechanism, there is a redistribution of blood flow from coronary to splanchnic vascular bed. After the food is consumed, there will be a redistribution of blood from the coronary to splanchnic bed, and therefore there is increased myocardial oxygen demand. Redistribution of blood from regions supplied by stenotic coronary artery to those supplied by less diseased or normal vessels happens, and that leads to symptoms of angina. Now, secondly, you can have a cold-induced angina, exposure to cold. It precipitates an angina about 40% of the patients with symptomatic coronary artery disease. And peripheral vasoconstriction, it increases the BP, leads to increased myocardial oxygen demand. And cold intolerant patient, abnormal baroreceptor function happens. And also it may be a marker of coronary vasospasm. And because in cold, the patient may have a atherosclerotic block, vasospasm occurs. The vessel becomes smaller, and then the flow again becomes reduced because of the spasm. The diameter of the vessel is becoming narrowed, and the patient may have angina. That is why we also say that in winter, the people may complain more of angina. And just like that, even the peripheral arterial disease like Raynaud's also is a manifestation of cold. So the cold will precipitate the vasospasm and aggravation of the symptom happens. So this is cold-induced angina. Then another variety is warm-up angina or second wind angina or first effort angina. And here the patient with IHD have exertional angina that forces them to stop. After a brief period of rest, they are able to continue with minor or no angina. This is also sometimes, most of the times actually, the patients say, I started walking, sir. In the example I said, after walking 1 kilometer, I have a discomfort. I sit down for 5 minutes, then I walk, I go all the way in the park, nothing happens. That is the warm-up angina. The mechanism here, important thing is the myocardial adaptation happens, and then there will be adaptive downregulation or there may be a collateral recruitment, because when one artery blocks, the other artery will supply collaterals. That may also be a helpful thing. The other thing is called walk-through angina. Here, angina early in the course of exertion, it comes and subsequently it subsides despite continued exertion. So this is important. It is different from what I have mentioned earlier. And in this, the patient continues his effort. He is not sitting or he is not stopping. He continues to walk, but he is able to overcome the angina and he continues to walk. Though we advise them not to do that, some people will walk because the anginal perception is mild. They may be able to continue. Rarely found during exercise testing also. So this is probably because of multiple mechanisms. Increase in coronary vascular tone with reduction in coronary blood flow at the beginning of exercise, which improves by recruitment of collaterals. So that may be a reason for walk-through angina. Usually, if the patient has postprandial angina or walk-through angina, significant symptoms may be there. The other one we call is a nocturnal angina. Nocturnal, as you know, it means in the night time. The patient will complain of angina during the night time. That is seen classically in patients who have severe aortic regurgitation. There may not be associated atherosclerosis, but the patient will have angina in the night time. And second is fringe metal angina, otherwise called a coronary vasospasm, and syphilitic aortic regurgitation. In this, there may be ostial lesions. Ostium means the beginning of the coronary artery. If you look at the anatomy, aorta is the main pipe that comes out. At the aortic roots, you have the coronary arteries that come out. And the point where the artery comes out is called the ostium. And in syphilis, classically, the ostia of the left main or the right coronary are involved, and they may have the nocturnal angina. This is another important thing. Now, primarily, it is due to increase in demand, as we know, and increased demand during sleep and dream-related adult surge can be an explanation. Coronary vasospasm or a nocturnal gap in the anti-anginal medication. These are some of the explanations given for nocturnal angina in coronary artery disease. So this is another variant of angina. It's called variant. These are different variants. Angina decubitus is another name. Pain identical in nature to effort angina, occurs during night in recumbent position. Frequently awakens the patient and tends to be of longer duration. Again, these people also have severe CAD. Mechanism is increased myocardial oxygen demand caused by expansion of blood volume with increased venous return during recumbency. So when the patient is lying down, just like your pulmonary edema or the orthopnea, PND, etc., which happen, the same thing is happened to the heart. When the patient is lying down, the venous return is more, the load on the right side is more, which is transmitted again to the left. The patient may complain of angina because some amount of supply demand imbalance is happening there also. And lastly, this fringe metal angina is a special variant. It is seen more commonly in Asian people like Japanese or Koreans. We see that. Also, it can be because of the drugs like cocaine in our places. It is called fringe metal angina or vasospastic angina or angina inversans. Recurrent episodes of chest pain at rest or during sleep. This is classical and it is due to coronary spasm. There may be a coronary artery disease in 1/3. Importance of this fringe metal angina is there will be ST elevations, but this is not a myocardial infarction. When we say angina, it is not causing myocardial damage. It is a harbinger of that symptom. So fringe metal angina is one of the important things because sometimes there will be severe spasm of the coronary arteries. Total flow may be stopped. These patients may have sudden death because the severe spasm is producing VT, and the patient may collapse. The other thing is microvascular angina, otherwise called cardiac syndrome X. This is commonly seen in women. So when we perform the tests, they are abnormal. When we do the angiogram, they are normal. That is a normal epicardial coronary arteries. Here, the explanation is that it is because of the increased microvascular resistance. So this angina is again longer with a slow resolution, more common in peri or postmenopausal women. This is called microvascular angina. As the name suggests, the epicardial big arteries are normal. The smaller branches which go into the muscle, they may have increased resistance, not atherosclerosis. They may have increased resistance. And then that may produce angina. And usually their prognosis is very good because there is no atherosclerotic blockages. They are unlikely to have myocardial infarctions. And they respond very well to calcium channel blockers. Like a diltiazem, if you put, they do very well. And the symptomatic relief is also better in them. The other thing you can use them is the nitrates. Now, lastly, variable threshold angina is another one, which is also for mixed angina. In patients with stable angina, sometimes develop coronary vasoconstriction and transient decrease in coronary blood flow. This is called supply angina. Abnormal vasoconstrictor response to exercise is the reason for this. So, in sometimes they are better, and sometimes they may do minimal activity and experience angina. Crescendo means progressively increasing frequency of angina. Actually, it is turning into unstable angina. So, what is stable over a period of time? If the patient says, "Sir, previously I was going 1 kilometer, there was no problem. Gradually now I am unable to do that much. Now, even if I go to bathroom and come out, I am having a angina. Or if I take a shower, I am changing clothes, I am experiencing chest pain for the last 1 week or 10 days." That means he has turned into an unstable angina. So these unstable angina patients need to be immediately hospitalized. That is a very important point. All stable angina patients can be investigated on the outpatient basis. We can do a ECG, we can do a stress test or a nuclear test, subsequently a CT coronary angio or a coronary angiogram in stable angina patients. But in unstable angina patients, the mechanism is different. It is going to be a plaque rupture. So these patients, if you do the cardiac enzymes, in stable angina, cardiac enzymes are normal. The troponins are normal in angina, but in unstable angina, myocardial infarction, they are elevated. So that means myocardial damage is happening. These patients need to be hospitalized. They need to be treated with anticoagulant. They should be antiplatelet agents, and then subsequently angiography, revascularization, they should be considered. Now, I think that completes my talk about the angina, but it is not complete because the title that is given to me is the chest pain. So all the mimics of chest pain also we have to discuss. Esophagus is also known to produce the discomfort here. But one of the important things I want to tell you is any discomfort in the esophagus has got a highly localizing value. The patient will tell exactly where the problem is. They usually complain of a dysphagia or a burning sensation, but they will be able to point it with a finger. Whereas our colleagues with the angina, they are unable to do it. So I had recently one patient, elderly lady, we did a stenting, and nowadays we load the patient with the antiplatelet agent. The capsules are given on the table itself and we proceed with the angioplasty. This lady was treated. Second day when I went to see her, she said, "I am having difficulty in swallowing." When I asked her to show, she said exactly here. So that means it is an esophageal problem. Immediately I ordered an endoscopy, and on endoscopy, what I suspected came out as correct. It was a pill-induced esophageal ulcer. So the pill which was given, because in the cath lab she is lying down, not enough water is allowed to be, taken in, and the capsule stuck to the esophagus, and gradually, because that capsule is a gelatinous capsule, it eroded into the esophagus and produced an ulcer. So she was able to show it. And similarly, the burning sensation, etc., which they described, you can clearly make out. And there is a relief with the water or antacid. Definitely, they get a relief, and that is going to be understood. The burning sensation which they described is one of the important things in the esophagus. So it is substernal, it's a squeezing or burning sensation precipitated by exercise, emotion, or food. Again, radiation may be there. The relief with nitrate also is there. So because the sphincter is a little bit relaxed, it can produce a relief. So you have to be very careful. The best way when you are in doubt is to consider and rule out the angina. So how can we do that is do a ECG, and we have the guidelines to do a serial ECGs. The first ECG will give you only 25% value. You wait and repeat another ECG after some time, then you may be able to get more information from the ECG. Changes may appear on the ECG, and then you can conclude whether it is an esophageal pain, or subsequently you can send him for an endoscopy and see, or give an antacid trial. If your risk factors are not much, low risk patient, he is young person with these symptoms, you can try antacids and see. So the differentiation is by provocation by swallowing. I said eating and drinking can precipitate this. So they will be able to show you in supine position, nocturnal stooping forward, they will be getting a relief by stooping forward. And the radiation to back also can be there. Acid reflux or water brush is another important symptom, and relief with antacid will give clues that it is a esophageal pain. Musculoskeletal pain is aching, you can know. varying in site intensity and duration, varies with posture and movement of the upper body. Local tenderness, as I mentioned, is one of the important things. So local tenderness can increase or totally decrease the pain. Then you are sure that it is not cardiac, because cardiac pain cannot be superficial. The psychogenic chest pains are called Da Costa syndrome, neurocirculatory asthenia. It may vary with mimic angina, commonly but not exclusively in women with other symptoms of anxiety. So localized dull persistent ache lasts for hours to sharp lancinating stabs of 1 to 2 seconds. So this is important. I told you any pain that lasts few seconds is unlikely to be angina. And psychogenic chest pain can develop in two situations: relative or friend who is recently diagnosed to have a heart disease in the period following myocardial infarction. Also, they can have psychogenic chest pain. Now, clinical classification I mentioned, typical angina has got the substernal discomfort, provocation or relief. These are the 3 points. Atypical is when it meets 2 of these criteria. Non-anginal chest pain is lacks or meets only one of the or none of these 3 characteristics. Then you say that it is non-anginal pain. So this table I think is important. It summarizes all the points which I have shown. So if it is a typical angina, you send it to the cardiologist. If it is atypical, then you can take a call. If it is non-anginal, then look for other causes and then treat it. Now here the yield or the persistent likelihood of coronary artery disease in symptomatic patient according to age and gender. This is also very important because you will get an idea. Suppose if a man who is elderly, 60 to 69 years, comes with a typical chest pain, his chances of having significant disease are 94%. Whereas a young man, 30 to 39 years, if he comes with a non-anginal chest pain, his chances are only 4%. So age is very important, and the gender is also important. The predictive value becomes more in men and less in women. Predictive value becomes more in elderly people, less in younger people. Now, always we have to correlate with risk factors, because the angina or myocardial infarction is related to the deposition of cholesterol within the coronary artery lumen, leading to significant narrowing or producing a supply-demand imbalance. So, if someone has got risk factors, his chances of having the atherosclerotic blockage are very high. And therefore, all elderly people, male gender, diabetics, dyslipidemia patients, hypertension, CKD, family history, tobacco use, and presence of established vascular disease, they all increase the likelihood of coronary artery disease. So suppose if you have a diabetic patient, again, diabetes duration is also important. If someone has got a diabetes duration of more than 10 years, he is likely to have target organ damage. So that is important. So even though he is young, if he is having a 10 years or more of diabetes, that is important. Whether it is controlled or uncontrolled doesn't matter. The duration or chronicity of diabetes is important. So a 50-year or 60-year-old diabetes, dyslipidemic, hypertensive patient comes with a atypical angina also, your suspicion should be high. A young patient without any risk factors, if he comes and gives the symptoms, then you are going to look at it with more suspicion, evaluate more. So, atypical angina is more common in diabetics, in elderly people, and in women. Sometimes they may not have much of the radiation and other symptoms. That is also very important. Now, sometimes we also have angina equivalents. So a patient with the diabetes, their nerve endings are insensitive to angina, and they may present with only shortness of breath on walking. So dyspnea or exertional shortness of breath is an anginal equivalent. So you can suspect that it is, because when he does the effort, dyspnea occurs. When he stops, the dyspnea subsides. But there may be other things. Extreme fatigue may be a manifestation, diaphoresis, and faintness, belching, nausea, and indigestion. They may be angina equivalents, but most commonly we treat only dyspnea as an important angina equivalent symptom. Now, when the patient says the symptoms, severity should be assessed. So all of you should know this CCS system, that is Canadian Society of Cardiovascular Society system. And here the class 1, 2, 3, 4 is mentioned. Just like your NIOH classification, you should know this. Class 1 is ordinary physical activity does not cause angina, such as walking, climbing upstairs. Angina occurs with strenuous, rapid, or prolonged exertion at work or recreation. And class 2 is a slight limitation of ordinary activity. Angina occurs while walking or climbing stairs rapidly, walking uphill, walking or stair climbing after meals, in cold, in wind, or under emotional stress. All these points we have discussed are only during few hours after awakening. Angina occurs on walking more than 2 blocks on the level and climbing more than 1 flight of ordinary stairs at a normal pace and in normal conditions. That is class 2. And class 3 is marked limitation of ordinary physical activity. Angina occurs on walking 1 to 2 blocks on the level ground, climbing 1 flight of stairs in normal conditions at a normal pace. So it is a progressive. And class 4 is inability to carry out any physical activity without discomfort. Anginal symptoms may be present at rest. So if the rest anginal symptoms are there, that means the disease has advanced. The patient needs immediate attention, hospitalization. Now this is different from NYHA. NYHA is for heart failure and the symptom evaluation, but this CCS of the angina is only, the CCS is only for angina. It's more objective. 1 block means 100 to 200 meters in USA, and we don't use these blocks actually in our place. And 8 to 16 blocks is a mile. And 1 flight of stairs means a set of stairs between floors, roughly 12 steps. So the patients will ask, especially after the time of discharge, can I go stairs or how much can I walk? Then either you can mention in the form of meters or you can mention in the form of time. So 10 minutes of walk or 15 minutes of walk if he is okay. That is how you can advise the patient. So this is analog scale. I think it's not important. 6-minute walking test, especially this is also useful for patients with stable CAD and also for heart failure. If the person is able to walk 6 minutes without symptom, then it is a good physical condition of the patient. So now after describing angina, we have to see what are the causes. So one is atherosclerotic coronary artery disease I mentioned, and there are some non-coronary causes also. So non-coronary causes where the demand is more. So for example, aortic stenosis, it produces left ventricular hypertrophy. Severe hypertension, again LVH occurs. Hypertrophy cardiomyopathy, there is a left ventricular hypertrophy. Though the blockage is not there, the demand is much more. So this left ventricle is more hungry and we are giving only the same amount of blood. Therefore, the patient will have symptoms of angina. Similarly, right ventricular hypertrophy can occur in severe pulmonary hypertension. And that is one of the non-coronary causes because it is related to the muscle hypertrophy. Severe anemia, because hemoglobin is low, it is unable to deliver the amount of oxygen to the left ventricle or right ventricle and can produce symptoms of angina, or pre-existing angina may be worsened if the patient is having anemia. So therefore, that also needs to be paid attention to. And when the patient comes to you, it is mandatory to examine the sclera. Though it is out of fashion now, I think it should become a habit to examine the patient, to look for the sclera, look for the in aortic stenosis. I mentioned all these conditions, it is increased demand and then decreased supply also can be another thing, because diastole is shortened if the heart rate is more. LV EDP increases, that also can cause decreased coronary perfusion pressure. Same thing in HCM also. In aortic regurgitation, nocturnal angina we have mentioned, decrease in heart rate, prolonged diastole, increase in AR, LV EDP increases in these conditions, and that leads to a decreased coronary perfusion. And diastolic coronary stealing also happens due to Venturi effect of the aortic regurgitation. This is an important symptom. In mitral stenosis, it can happen maybe secondary to pulmonary hypertension and right ventricular hypertrophy. In elderly people, there may be associated atherosclerosis, and another cause is acute coronary embolism. In mitral valve prolapse, it is atypical, definitely unrelated to exertion, but you may have STT changes on the ECG. On auscultation, you will have the findings of mitral regurgitation, the murmur you can get. In pulmonary hypertension, angina is a common symptom. We have mentioned that it happens in 15 to 20%. It is because of RV ischemia. Rarely, it may be compression of left main by dilated hypertensive PA. We have seen some cases like that. In a couple of cases, I did a stenting also of the left main because it is a compression of the pulmonary artery causing obstruction to the left main. So when we put a stent into the left main, it is not compressed and angina is relieved. So I think briefly we go about acute chest pain also. It can be acute coronary syndrome. So as I mentioned, the time cutoff is important. If the symptoms are aggravating and more than 20 minutes happened, that is acute coronary syndrome. Or if the threshold has changed, that is acute coronary syndrome. So another important feature of a myocardial infarction or unstable angina is a crescendo type of pain. So the patient says that the intensity of pain is cascading. So initially it was on a lower scale. As the time progresses, it increases more and more. And for your information, if anyone wants to experience how angina will be, what you have to do is you tie the BP cuff to your arm and increase it to more than 200 and wait for a few seconds. And then the feeling which you get in your left muscle or the left arm is described to be similar to the anginal pain. So that is the kind of pain or the discomfort which a patient experiences. So I think it is safe. All of you can try and see. Tie the BP cuff, increase to 200, wait for a few seconds, and see how you have the feeling. That is the anginal pain. And if it is intolerable or high in intensity, that is a MI pain. Aortic dissection is another important thing. We have to know in aortic dissection, the patient again has a localizing value. So he will tell you how the dissection has progressed. So he will describe it as a tearing pain. So I have a patient who came to me long ago. He started having acute chest discomfort, and then he described that something was tearing in my chest, and it spread like this from here all the way up to below umbilicus, and it stopped at the lower part of the umbilicus. So imagine the person having a dissection at the arch of the aorta and slowly progressing down all the way up to the bifurcation. So this is exactly what we found when we did a CT angiogram, and you can see that what the patient has described. The CT aortogram has shown a dissection from the arch all the way extending up to the iliac bifurcation. So that is how the patient can describe. So these are the localizing values of certain conditions where the patient will tell you. And pericarditis also can come acutely. Sometimes it is mistaken for coronary. In pericarditis, the patient will try to stoop and get a relief, and that is called Mohammedan posture prayer, prayer posture. And then there will be a trapezius ridge radiation in pericarditis. So instead of coming to the hands, it will radiate to the trapezius ridges. That is a classical one for the pericarditis. And if you auscultate in the stooping forward posture, you can get the pericardial rub. So if you want to hear the pericardial rub, catch hold of a few strands of your hair and rub it like this. So what you hear in your ears is what is pericarditis. Other causes are pulmonary embolism. Rupture of sinus of Valsalva is a rare disease, and this also can come as an acute chest pain. And non-cardiac also can sometimes come as acute, but if none of the symptoms I have highlighted are there, it can be brushed off as a non-cardiac pain. So ACS pain already I have mentioned. The duration is important, the intensity is important, the cascading is important, the associated symptoms are important. Especially in acute MI, the diagnosis can be very, very easily made. The patient will feel cold and clammy. It appears as if he has taken a shower and come out of the bathroom. So if the severe chest pain is there and it is cold, that is the clinical sign you can make out acute myocardial infarction. So dissection I have mentioned, how the tearing pain is important. Likelihood ratio is 11, you can see here. And dissection chest pain is more common in type A than type B. So type A are more proximal dissections, type B is a distal dissection. And sometimes it involves right coronary artery. So it may present with acute inferior pattern. Dissection can radiate also, that we have already discussed. Pericarditis I have mentioned. Radiation to trapezius ridge is highly specific. So there are some salient points which you have to catch from the lecture. So I try to give you all those salient points which are going to be very highly specific for each individual cause of the chest pain. Pulmonary embolism, dyspnea is the main symptom. Substernal discomfort may be there, but it is rare. Pleuritic pain can be there because of pulmonary infarction. And if you are in doubt, the best thing is to do a triple rule out, what we call. There will be a diagnosis by doing a CT angiogram, where you get the information about the coronaries, about the pulmonary artery, and also about the aorta. So in the emergency department triage, the triple rule out is one of the important tools where you can accurately make a diagnosis if you are not sure what's happening. But however, when you analyze these symptoms, I think it is very clear Now you can make out angina from non-anginal pain, cardiac pain from non-cardiac pain, and also I try to give you the other things. I did not discuss about the cholecystitis and other things because the symptoms are different. Vomiting sensations, nausea, those things will be there. Acute abdomens and other things I didn't discuss. But generally, I try to give a bird's eye view of the chest pain evaluation with different causes. Mainly, I focused on the cardiac angina and myocardial infarction because that is our forte as a cardiologist. So to conclude, detailed clinical history can differentiate various causes of chest pain. Along with physical examination, it can provide information for selection of proper investigations and thereby avoiding unnecessary risk of other tests and also risk of being missing the proper diagnosis. So always it is our endeavor to do best to our patient. So try to spend time. I always tell my students, you stay with the patient for 5 to 10 minutes in the initial part. The patient will tell you everything, all the details will be there. And you always make it a point to examine the previous reports. So that also will save you time. And also, don't believe those reports, but you analyze those reports and compare with what your findings are there so that the patient will be benefited. So I think with that, I conclude. I think I am still sticking to time. 1 minute I have left. So any questions and comments are there from my teacher, Dr. Balraj sir. Thank you very much for giving me the opportunity. And any questions are there? If time is there, we can take it.
Thank you, Dr. Pramod, for your excellent talk.
Thank you.
I think both the broad specialties and super specialty students have been, they have got the advantage of listening to you, and then they are benefited with this class. And then one advice from my side is to the students is, in a chest pain, when you are unable to conclude or to come to arrive at a diagnosis or a point, better keep them under observation rather than sending them home, because costly mistakes are made when you say that with single ECG, and then if it is found to be normal, you are sending, and then they collapse, they succumb near the house. So this is very, very important. When in doubt, when the seniors are not available with you and then you are unable to make a judgment, please do keep them for observation. This is my sincere advice. And once again, thanks, Dr. Pramod, for an excellent talk. Both not only chest pain, the cardiology aspects, as well as the non-cardiology aspects also have taken. This has definitely benefited the students of broad specialties as well as the super specialties. I think such classes will also we are going to take, and Pramod, we also request Pramod to be in future such classes to be will be handed over to him, and then he will be there. So if there are any questions, please do ask, because this is an once for all, you can finish up teaching on the chest pain. If you got doubts, he is ready to clarify and then make use of his presence here.
Sir, can I ask one question?
Yes, please go ahead.
See, in the acute coronary syndrome algorithm, proposed by the AHA ACLS group, once the patient comes with chest pain, in the emergency department, the vital signs are checked, IV access is obtained, physical examination is done, cardiac marker levels are done, chest X-ray is done within 30 minutes, and a 12-lead ECG is done. And here I was suggesting them to include echocardiography, bedside echocardiography, at least to make out any cardiac condition, so that by chance, if patient is taken to cath lab based on ECG, in some instances there were negative coronary angiography findings. So I have suggested to them to include bedside echocardiography. We're not asking for a detailed echocardiography, but bedside echocardiography may be useful, especially if there's aortic stenosis or acute aortic dissection mimicking coronary syndrome.
Absolutely.
So what is your impression on that, sir?
I totally agree with you. And here it is a part of our ER setup. We have DNBs and DM associate cardiologists. They go there and they will do a screening echo. And as you rightly said, aortic stenosis or hypertrophic cardiomyopathy or fusions, and sometimes pulmonary embolism, they all can be made out by a bedside echocardiography. And I think abroad they have some regulations for doing these things. They need the time and all.
Yeah,
So
yeah, yeah.
they have their constraints. But in our country, I think we are free to use the echo machines, and
Yes,
we
yes.
can take a look at what's happening. And as you rightly said, if the patient is wheeled into cath lab also, this
Yes,
information is going to be very, very helpful. And
yes,
in
yes.
some cases, actually, where the people have become little lax in auscultating, uh,
Correct.
they made out MR and they made out VSDs by doing an echo rather
Yeah,
than,
yeah.
because there is a tachycardia, they are not sure what it is, acute MR
Right,
and VSD.
right.
Absolutely, I agree with you.
Can we do our national guidelines and include echocardiography there?
Screening echocardiography, definitely yes, because
Yeah,
in acute condition there is an emergency. The time is running. So
yeah.
if
Right.
you say that in all places, logistically it may not be possible. So they may keep the patient there, asking for a cardiologist to come from some time and then do it, setting up the echo machine. And all.
Now the times are changing. Even emergency physicians and critical care specialists, they are reasonably good in surface echocardiography.
Yes, absolutely.
So
Screening echo.
yes, sir.
Correct.
Thank you. Thank you for your response. Thank you, sir.
Welcome.
Question and answer session, sir. Question and answer session.
Yeah, anybody would like to interact?
There is a question, sir, from Rajiv Kumar. A young female 35-year hypothyroid with history of panic disorder, presenting with chest pain with ECG changes of ST depression more than 5 millimeter in anteroseptal leads. Should go further evaluation or not? Yeah, again here, because it is a young lady and hypothyroid, 35 years, we are seeing cases of atherosclerosis also in them. And if these changes are downsloping, then it is more important. And then we can definitely, work up on this patient. If the changes are horizontal or upsloping, then it is not important, because if the patient presents with a tachycardia, especially in a panic situation, there may be ECG changes sometimes. Upsloping changes are common, but the value of upsloping changes is not that much. If the ST depressions are downsloping more than 5 millimeters, definitely we should evaluate this patient, because age is 35.
Anyone, please? And we also request you to have a suggestion from your side, and then you want in a different style or further anything you are thinking more than this type of teaching. Your suggestions are also will be welcome, and we'll definitely look into it. You can suggest us without any hesitance.
Yeah.
So I think there are no questions or there's no comments or interaction. Should we close?
Yes.
Yes, sir. There are no other questions. We thank Dr. Pramod and Dr. Balraju for your time. Okay, Association of National Board Accredited Institutions would extend their gratitude to you both, sir, and to all the participants of the session, sir.
Thank you very much.
Thank you, sir, and good
Thank you
evening,
for
one and all.
providing this opportunity.
Thank you, Dr. Balraju, and thank you, Dr. Pramod.
Thanks a lot. Bye.